which means that if you find a prostate cancer in a 60-year-old only because you went and did a platinum health checkup and a serum PSA was done which was high, and you tell the patient, don't do anything, we'll repeat the MRI after 1 year. If it remains the same, we'll repeat the MRI after 1 more year. And until it grows or you become symptomatic, nothing is to be done. Then the reverse question is, why do the PSA in the first place if in any case the best thing to do for a patient is to do nothing to begin with? You know, so it is an interesting conundrum. I haven't done my PSA, I'm 58, I'm not going to do one. I do a lot of testing. I do my lipids every 3 months, etc. But I will not do a single cancer screening test for myself ever. Because if I'm asymptomatic, no screen detected cancer is worth treating at this point in time. If I was a smoker, then an LDCT would work. In women, it's different. You do HPV DNA for CA cervix. It's a must every 5 years till 65, and a mammography. These are the only 2 things that are required. And I'll tell you how things go rubbish, right? Last week, a GP called up saying that, and this was somebody who had come from the US and did this platinum health checkup with CEA levels and CA99 and all that crap, and one of them was borderline high. Borderline high means abhi PET CT karenge to find out why it is borderline high. But why do the tumor markers in the first place? Unless you have a family history of CA ovary, or you have a family history of malignancy, or some high risk factor, doing a test to try and find out cancer in the hope that by removing it early you will make a difference doesn't make any sense at all, because it doesn't change what would have happened in the future if you had the cancer and it presented when you were symptomatic. So it's a lot to think about, and sometimes the simplest thing is to just go with the flow and just do what everybody is doing. But do understand that cancer screening is a completely different ball game, and the only proven data that we currently have is for breast cancer, lung cancer in smokers, HPV DNA in CA cervix in non-high risk people, and serum PSA to half an extent. That's it.
Colonoscopy.
And colonoscopy for colorectal cancer. That's it. Nothing else. So that's that.
Okay, I think we'll end the formal talk here. Before sir goes, a small token from all of us. He's an avid reader, so some books for him. And thank you all for coming, quite a good number, and hopefully see you next month here.
No, I always like to have the last word.
Yeah, of course.
I did not know what to expect. I don't know how, you all know the efforts that Tushar puts in. He came to meet me, and I live in King Circle, so for me it was best that he comes there. So we had coffee at the Starbucks at Khalsa College. We spent an hour and a half. He told me everything that he does, but I still didn't understand how exactly this works. And I am so impressed. I mean, this is such an amazing thing, Tushar. My God, yeah. Hats off to you, and congrats and everything.
I will have to thank him that he agreed to do it without PPT. We are doing an imaging talk without images, and yeah, but you could see how useful it is for all of us. Thank you, sir. Thank you so much. Forward. What is